Hello, and welcome to the first episode of this podcast from MGI. As World Cancer Day is approaching, today we're going to talk about precision oncology, and we'll be joined by Professor Marie-Laure Yaspo, who is the Chief Scientific Officer at ALACRIS Theranostics, to talk about her work on molecular tumour profiling. So, to start with, Marie, thanks very much for joining us. Can you tell us a bit about your background and how you got involved in the founding of ALACRIS Theranostics?
Yeah, thank you. My background is I'm a molecular biologist, and I have been involved in the Human Genome Project and International Cancer Genome Projects. During our work, it really became obvious that with a deep analysis of genome and transcriptomes, we could gather so much information on the tumor landscape, on the tumor biology, that we understood that could play a very important role in personalizing therapy. So naturally, that became a major focus of my research as well. And the idea of translating this research for developing innovative cancer diagnostics led actually to the foundation of ALACRIS Theranostics.
Excellent. So you touched on it already a little there, but can you talk us through sort of the history of how ALACRIS has evolved from being more of a research project on sort of cancer consortium projects into being more focused on precision medicine for oncology and comprehensive tumor profiling?
Yes, that was, in a sense, a natural evolution. We founded the company. We are scientists, molecular biologists. The three founders are myself, Hans Lehrer, and George Church. So we are genomics people. So we were first developing the systems to look better into the tumors. And our mission is to enable personalized therapy for all cancer patients. And I insist on the all cancer patient, because from the research projects, we learned how complex and unique the molecular landscape of every tumor is or can be, and that even within a given tumor type, you have this very unique pattern. And within this landscape, we could detect potential targets. So from this and the knowledge and the expertise, we evolved to translate this knowledge to diagnostics. So that was, in a sense, a natural evolution to have spent a decade on research, but always with the vision of translational oncology, translational medicine.
So a big trend in many, sort of analytical fields recently is multiomics in life sciences, or multimodal analysis, in lots of ways, where you can get a more complete picture of many studies by using different techniques to show you different aspects of a system. How does that play into tumor profiling? As well as the genomic project and studying that. Like, what other modalities do you use? What other analytical techniques do you use? And how can they sort of complete the picture?
Well, tumor profiling is it's a word. You can profile DNA, you can profile transcriptome, you can profile proteins. The more information, the better. And, it's a bit counterintuitive, but the more the data are complex and deep, the easier it is to find your targets, right? It's just a matter of having the right analysis system and the right strategy to look at the data. Because, when you ask me that question, we should not forget that in a tumor, most people think of DNA mutations are, chromosome changes, but a lot of it is what we call epigenetics. Epigenetics is a change in the chromatin structure. You don't see it really by sequencing DNA. You see it because when you change the structure, you change the gene expression. You get some genes go up, some genes go down, and this is what you see with transcriptome analysis. So when you have different levels, you look at different aspects of actually the same thing, how the tumor is changing its program. And that's what we need for the diagnostics.
And is that something that changes from patient to patient as well? Obviously, even if the underlying mutations are of a similar type, is that where some of the requirement for precision medicine and more personalized approaches, is it outside of sort of the core genome where those kind of personalized changes are happening in the tumor?
Yes, it is. I mean, of course, when you are within a tumor types, you have communalities between patients, between the tumors of the several patients. But at the same time, you have those little alterations which are going to be different. And that you could harness in some types, not always, of course, but you can. And one typical example is tumor microenvironment. The tumor is there, forms a new um, abnormal tissue in the body, tumor tissue, but then it's not alone. There are other cells which come there, like the immune cells in the body, and they try to eradicate the tumor. The tumor reprograms those immune cells so that they become inactive. They are called, for instance, the regulatory T cells. And this profile of the immune cells which have infiltrated the tumor, you can only read it out by using what we call bulk RNA-seq.
So the other aspect, I guess, is ultimately the idea is to improve clinical treatments for cancer, right? That's the aim of the research. Oncologists in the clinic will have some idea of sort of cancer biology and how it works, but they won't be sort of genomics experts. They they won't have the depth of understanding of the biology of the cancer at this level. So how do you sort of pull the actionable insights from the research that you're doing, from this deep molecular profiling of tumors, and translate it into these clinical insights that doctors can use?
Right. Yeah, that's correct. When we deliver the tumor report, we don't expect the doctor to start, a new lecture on molecular biology. So the way we do it comes in several levels, right? You have the mutations, not so many are directly targetable. It comes with pathways, for instance, HRD, and then you have a treatment, the olaparib, for instance, and then you have the tumor microenvironment where you can say, well, if you have this particular estimation of immune cells and immune cell markers, immune checkpoint inhibitor, we can that can help to design the combination therapy, for instance. Because nowadays, cancer treatment, it's not anymore, well, rarely one alteration, one drug. It is in some entities it is still that way and that works, but most of the time it's combination therapy. And for combination therapy, you need to really see through the tumor what you could combine and when. I don't know if that answers your question.
Yeah, definitely. It's obviously it's not a straightforward process.
No, it is not a straightforward process. That's true, but it's a stepwise process. In the analysis program that we have, no, we have many steps and we use many algorithms which are aggregated together and then we sieve. And the way you sieve, you do have references to allow you to say, oh, that is abnormal, that is not so sure. And we pick out and sieve the most relevant variants we are really sure are the ones, the key ones among the mass of the data. So that's, again, the needle in the haystack. But to find the needle in the haystack, yeah, you need to have the haystack to look first. And that's what we deliver. And then we match with drug databases. They have databases of clinical trials and drug targeting this and that alteration that we don't invent it. And this is when you have your set of alteration, then you look which therapies could fit to this, could match this alteration. So we have a personalized patient match um, therapy choices. But then it remains to the oncologist's choice to pick one or two or a combi or none at all, depending on the patient status of those therapies. Our job is to read out the tumor story.
And yeah, I was going to say before, that's kind of the whole approach of precision medicine, right? It's kind of the other side of developing treatments. Like we can have better and better drugs and develop cleverer drugs, smarter drugs, better delivery mechanisms. That's all important. But actually, we already have some really good drugs, and it's just about choosing the right ones at the right moment and the right combinations for that tumor for that patient. And that's it can be hard to explain because it's going to be a different process every time. You go through the same steps, but you're going to every tumor is different.
It is, and it is also a paradigm shift, well described paradigm shift in the treatment strategies. Yes, I was mentioning a bit before you. There was this again about a decade ago. One mutation, one drug, but there are not that many. There are about 25 drugs which hit directly a mutated product, to act on the structurally changed protein. But all the rest is more mechanistic. Of the DNA damage response or on MEK inhibitors. It is more mechanistic, and there is this paradigm change to go more tumor agnostic in some case, but more mechanistic. And to go mechanistic, to have the mechanism, and it's where the comprehensive profiling is really supporting this paradigm change.
Excellent. So let's get a little more technical. Talk about some of the steps in the sort of process in the pipeline that you were talking about. How do exome-seq and RNA-seq contribute? With analyzing chromosomal volumes, mutation scoring. How do those play in to the overall picture of the data that you build up in this pipeline?
Right. How they play together, they increase the scope. Yeah, you have much more data. That's a bit the iceberg vision with exome-seq or even whole genome-seq. Whole genome is of course better than exome, but if with the DNA only, you see the tip of the iceberg. When you add RNA-seq, you have access to much more information, which is useful. But also you provide what we could call an orthogonal validation, because if you score a mutation, you will look, do I see that mutation in the transcriptome? Because the transcriptome is the first readout of the genome. Yeah, the genome is mutated, but as it is, doesn't do anything. It needs to be transcribed in RNA to be able to do something which will be translated in a protein. So reading in the RNA increase automatically the precision, because for instance, if you have a false score in DNA, you will rarely see that call again in RNA-seq, which is a different experiment. So you have an orthogonal validation which increases the precision, but it's also a way to interpret the genome data. So I explained a little bit, if you have a mutation in a so-called splice site, which might change the structure of the RNA or not, well, before making a decision if that is going to be relevant, you have to look in the RNA. If there was a mutation in the splice site, is actually the transcript structurally modified or not? So this is why it is so useful. Another example we might want to quote is that you are part of the genome which got multiplied, amplified in cancer cells, and they contain genes. But again, what does that do to the tumor? If the genes inside those amplified regions are expressed at a much higher level, you get more and more of a product, and that push the cells to oncogenicity, then you read it in the RNA. But you have regions which are amplified, but nothing happened to the RNA. And in that case, it's hard to believe that those genes are relevant. So there are really two levels. Why this modality is so important. That's very technical again, but it's easy.
It is, yeah. That's fascinating, though. Yeah, because it's like you say, it's a whole other level that you don't necessarily think about, but it's just as important in cancer as it is in other aspects of genomics.
Yes, what we should never forget that the genome by itself, you have 2 copies with 2 chromosomes, but that's what you have in your cell. The key question is what happened to it. Yeah, of the changes in the genome. The genome is by itself is not an actor, it's a code. It's a information box, a code. Yeah, the code of the cell, the code of the tumor cell. So, of course, it's essential to read the alteration in the code, but it's equally essential to see what they do. Because what about if you have a mutation, but it's not propagated? So the genome is transcribed into RNA, right? And then the RNA is translated into protein. So that's a 2-step process to propagate the genome information. So the point of using RNA-seq, the transcriptome, is to read out the code, what the cell is doing with the code, with a new somatic cancer code. So, of course, if you have a mutation, you want to see it in the actual RNA because we have 2 alleles, and sometimes the allele which is transcribed is not the one which carries a mutation. So it's important to see how the code is propagated. Same thing of the epigenetic code. If you have a change which affect the promoter and enhancer, and you want to see if the gene is actually expressed or not expressed, you have to read out in the transcriptome. There's no other way. So really the transcriptome readout complement beautifully well the DNA score, which provides a functional readout of the code box. We have really to see the genome, which by itself is not the actor, it just has a code, and then the cell is using the code.
And do you run into any challenges communicating that sort of thing to doctors, to clinicians? Because to what
Yes.
extent is that understanding present?
So yes, it has been very hard to communicate. And it's still hard, not always, but it's still hard because typically there is people look at DNA. DNA, it's more comfortable because in DNA you have, you 2 copies per cell. It's a linear information. When you talk of RNA, it's a bit more difficult experimentally. And then you have the numbers. You have low express, high express. You increase the complexity. And yes, sure, a number of people, oncologists, doctors, were not comfortable with something which they were not exposed to, which I can very well understand. You come with this, and how shall they believe you? So now, of course, there's a trend going more and more into multimodal. So most people who use multimodal, which is still a restricted number of units, do it very often targeted. So they have a few targets in the RNA that they look at, but the bulk information is not yet widely used at all. And again, in the bulk information, you also read not only the tumor cells, but the cells which accompany the tumor and actually participate to the growth of the tumor. The immune environment of the tumor cell is incredibly important to the tumor. And this is why there are a number of immunodrugs, immune checkpoint inhibitors, which depend on this pattern. So it has to be read out as well. But it's difficult. It has been difficult, but the trend is evolving. We see this paradigm change to the multimodal.
Yeah, these things will gradually become more well known, more understood. But yeah, I guess at the moment it's as much a teaching role that you have as as well as just an analysis one.
Yes, because obviously that pushes the healthcare system and the healthcare providers out of a comfort zone, I would say.
Mm-hmm.
That's easy to have a mutation and a drug which targets that particular mutation. This is naturally a much more comfortable situation than having a pattern and reading out a pattern to propose a drug combination.
Yeah, that's fascinating. So do you maybe have a case study or an example that you could talk us through where you've provided profiling on a case and it's impacted the clinical decision and the eventual outcome? just to help sort of understand the whole process and how it can work in practice?
Yes, actually, we have a study which has been financed by the German government that we had together with the Charité Comprehensive Cancer Center in Berlin on melanoma, refractory melanoma, more precisely, was this kind of approach really allowed to zoom into the tumor and help support the tumor board to propose therapy. So this project ran on over 3.5 years, and we had a cohort of 100 kids altogether. At the end of the day, we even published the data. We have a new paper that we are in preparation. Basically, we could see a benefit for about 30% of the patient, which is very significant. So that you read out more, so you could propose a therapy. We read also gene fusion. Now, gene fusions are on the very large multimodal panel, able to see even with the targeted panels. But at the time when we started this analysis, you really had to read all the gene fusion from the RNA-seq, and we did and could find targetable alterations. So about 30% of the patient. And that has been a very important teaching experiment for us and for the tumor board to see how to use this type of data, how far the clinical use can be extracted from this data, right? Not all of this information can be used clinically. And that has been an essential teaching experience for both sides. We also have a project, it's more than a project, we propose these diagnostics for pediatric acute lymphoblastic leukemias, also at the Charité, and with Dr. Cornelia Eckert. And here as well, we make a large use of RNA-seq. They will add whole genome soon, but the RNA-seq has been what they have been needed. We have been doing that for the past 3 years now. And that again helps a lot to support the design of clinical trials.
Coming back to a more technical point again, so a lot of what you do, a lot of what's valuable about what ALACRIS can do is in integrating data from multiple sources, multiple analysis modes, as we've talked about, and then communicating that to doctors in a way that they can understand it and use it.
Yes.
But at the core of it is still the sequencing technology. So how important are the actual tools that you're using for the DNA and RNA sequencing?
Sure. Yeah, this is essential. So we need a technology which is very precise, very reliable. You don't want errors in the sequence. We want a technology which helps us to score accurately. But you also want a technology which is flexible in its format and dynamics. And I explained that in a bit more concrete examples. If you have a few samples in the analysis, which in routine needs a fast answer, you cannot wait to fill up your sequencer with other samples which happen to come next week. You just have to do it immediately. So this is why we turn to the MGI technology, because not only the technology is fantastic, has a so-called reduced duplication rates. It's a bit technical, but basically that avoids you to count the same mutation several times because you avoid duplicate reads because of the rolling circle technology. But the second super advantage is the format of the sequencer, right? You could have very small sequencer, but for our strategy, we sequence about, 40 to 50 giga when we want to go deep for the sequencing to be more precise. You need a sequencer which is larger capacity, but not too large, because again, otherwise, if you have to wait to fill up your flow cells. And the nice thing with the G400 is that this is medium scale sequencer is that you have one flow cell with 4 lanes. You can separate your samples and your lanes and your logistics of the sequencing, and that's incredibly practical. And of course, what shall we say? The third advantage, which is not the smallest one, are the cost. So the costs are become so affordable, in particular with this technology. You got better data, the format is more flexible, and the cost allow you to really introduce that strategy in the routine, because the cost is important. So we are within a range which is compatible with the health insurance cost, and for the time of the technology, because that also has to fit the patient journey. We are at a 1 week from tumor samples to giving the data nowadays, and that's really very fitting for the patient journey.
Yeah, that's a really important. The speed of the response is a
The speed
really
of
important
response is
factor.
important.
So yeah, you said the G400 is your main sort of workhorse. That's the main instrument you use. But did you add the T7s this year as well? Was that
Yes.
or last year?
So the T7 is also a fantastic instrument and can sequence up to 4 to even almost 5 terabyte of data within one run, with it, 35 hours, which is fantastic. We use it right now for whole genome sequencing. Some clients want to have whole genome sequencing, and as I was mentioning, for the pediatric leukemias and other units who want to add whole genome sequencing, we could use the T7, because then the costs are lower than the G400. So that is really the fantastic instrument when we introduce the VGS, and we use it also for the single cell sequencing. We do have some single cell sequencing requests, and single cell sequencing, the volume is high, but using the T7 at low cost is also shifting a bit the paradigm, how often we can use single cell sequencing. So of course that opens a lot of possibility, and when the service, we propose a service, increases in volume, we could use the T7. Also, we have two G400, and they cover well. They still have high capacity, cover well the demands from now.
And what's special about the cases where the clinicians all want to do whole genome sequencing, and what does that add for those cases rather than just, I guess, the tumor sequence?
Yes, that's an important question. Yes, the whole genome sequencing allows you to have a base resolution of the genome alteration, which you cannot reach with the exome, because the exome would have interrogate only the exons, which is only part of the genome, a small part, that's about 5% of the whole genome, and you interrogate the exons, so the coding part, and not the non-coding part. So basically, why they want to use that is to have a much better view of the rearrangement. Typically, hematological cancer have by and large what we call gene fusion. So you have gene rearrangements, which brings two different parts of the genome, which were on different chromosomes, far from each other in proximity, and create a fusion product. So the fusion product, we detect it in the RNA most of the time, but not what we call the breakpoint, because when you break a chromosome, most often the breakpoint is within a non-coding region. So you don't have information on the breakpoint, but then the breakpoint will put two genes together, and then on the RNA you will read the product because it's spliced out. But they need the exact breakpoint. And why do they need the exact breakpoints? Because then they can detect the MRD, which is minimal residual disease. In other words, when the cancer is treated in the blood, when the bone marrow, there is sometimes some clones which stays there at a very small amount and might grow up later to generate a relapse. And if you have a DNA test which could scan the MRD, this is of extreme value for the patient management. But to have the DNA test to detect these very low frequent events, you need to know the breakpoint. So basically, this is to define another diagnostics to detect the residual clones which could lead to relapse. So this is why it's so important.
So, we've talked a lot about the different aspects of what you do at ALACRIS, and you've mentioned that there's a lot of new developments. It's a pretty cutting edge field. There's new drugs, there's new studies coming out about different methodologies, about different therapy styles. And then there's new sequencing technologies. How much of your job is keeping track of all of that and staying at the as close as you can to the forefront and sort of picking out what advances are going to be important to you? How big a job is that?
Yes, well, that's a big job. I mean, at the same time, I was talking before. We can very easily do the transcriptome, but still, it's a lot of job to follow. Let's say to get the adoption for this type of diagnostic. But at the same time, we are already looking ahead. And of course, one of the technology which is particularly attractive also for diagnostic is the long read technologies, because when you have the short read for the genome, we miss some of the structural variants there. Also for the RNA, you have the structure of your RNA in a one piece. So it's easier instead of reconstituting the puzzle from the short read. So obviously the long read technology is one aspect which is going to help when the technology evolved. But also the single cell sequencing at low cost. If you have single cell sequencing, you have a better view, for instance, of the tumor microenvironment, of the heterogeneity of the cells, of the tumor cell, because you zoom in with a granularity that you don't have with a bulk RNA-seq. Also, the bulk RNA-seq is very insightful. You can deconvolve it. So those are complementary technologies to say. I don't think that we're going to swap from one to the other. But to add modalities, perhaps not for all cancer, for all patients, but for the cases which need additional information, if it's off the shelf, practical for the routine. Sure, we are looking forward to this. And in terms of technologies, another aspect that ALACRIS has been working on for more than a decade is predicting of the drug response. So that is not yet clinical grade. Right now, we make a very comprehensive diagnostics and match the drug to the alteration. But the next step is to use this data, this complex data, and use mechanistic in silico program, tumor modeling, to model the feature of the tumor if you would use 1, 2, 3 drugs and in which combination. And that is a predictive modeling. So we have that at ALACRIS, which is still in R&D. It's not yet clinical grade, but that's also opening to the future. And that is, we see this boom of the so-called AI, which sometimes is a buzzword to rename technologies which have been there before. But with a mechanistic modeling, you use the data of each tumor and the knowledge of the biological pathways to predict. So you are not depending of a huge mass of other data. You just it's easier said than done, but predict the future of the tumor placed in face of a number of drugs. So that's fantastic for preclinical platform, for instance, for testing, high throughput drugs on models, cell models. So that's what we are looking at.
Yeah, there's some fascinating stuff going on there. And there's certainly a lot to keep track of.
Yeah.
When you are integrating so many different modalities, different methodologies, and then the pipeline you have for integrating them together, and then applying that in the clinic. There's a lot of different moving parts there for sure.
Yes, what is going to be stepwise. I don't think we can do everything at the same time. So this is why we really focused the past years to develop the comprehensive diagnostics. From that, yes, you have always, when you have a bioinformatics system, when you have a product, it's in a sense it's always a prototype, because as soon as you finish it, you want to improve it and improve it. So there's also the continuous improvement of version 0, 1, 2, 3, 4, 5 as for any software. So that is our focus, and to go to the other technology stepwise.
Yeah, of course. And as you said before, even if you had a a giant AI model that could predict, how drugs will affect a tumor, then a new drug will come out and you'll have to change it anyway. So it's always going to be a work
And
in
you have to
progress.
validate it. So how you validate it, you need model to validate it. So I think that will be more for the pharma, so that our business model is more to offer this from the pharma. Of course, if we grow big, we could do it ourselves. We know how to do high content screening, but I think that can be done best by the farmers who are super equipped for that and have all the expertise of high content screening in different type of cells. Yes, that would be interesting developments.
Excellent. Are there any other sort of studies or research projects coming up that you're excited about that you think are going to be, big steps forward that you can talk about? Obviously, you don't need to leak anything that's secret.
No, there are no secrets. I think I wrap up more or less what are the different direction of the company, but as a kind of integration, the diagnostics and the prediction. We would like to be able to claim that. So we are working for this, talking of prevention, and for us, looking at tumors, it would be third level prevention, because real prevention, preventing cancer, I think that's not where we are now. But if for people who already have cancers, if we could prevent that the relapse goes too far by being able with the diagnostics to get options and biomarkers to follow up, so at least to be able to treat early enough with the right drug. So that is this so-called third level prevention, which we are looking at. And cancer is unfortunately a disease which affects a lot of people, a number of people throughout their life, and especially with the life being extended, there are more cases of cancer, of late cancer arrives later, apart for the rare pediatrics. And we would like to be able to go in that direction, to call it third level preventions, to read out enough to define, to help the oncologists to define patient management that fits. But that's also true for for the pediatrics as well, to be able to prevent relapse. This is also a project we have. We have actually 2 projects for pediatric leukemias, with several units, to read enough in the profile to be able to understand at the time of diagnostics, is this case gonna relapse or not? Because then the screening is more often is earlier, and the acting on it would be earlier. It's hard to prevent it, but it will be already a step to detect it early enough.
Yeah. That's fascinating. That's really important as well.
It is.
I know even in my lifetime, I remembered the typical statistics that are quoted for how many people will get cancer at some point in their lifetime has gone from being 1 in 3 to 1 in 2.
Yes,
And that's not because cancer's getting worse; it's because people are surviving everything else
yes,
more,
and
living
live
long
longer
enough,
as well.
and to
So of course there have been
and it just makes it more likely that you'll get it.
incredible progress in therapy, in patient management. I mean, the medical part is also playing, a huge part. And they are really impressed how, clinicians can manage the disease as well. But we need much more information to be able to act earlier and better. And it's an evolving process, like the diagnostic, the new drugs, the treatment, the new combination. Well, the difficulty of it as well in personalized medicine is that, with this uniqueness of the patient, of the tumor, you cannot really follow the model of, let's validate on a cohort, because where do you find a cohort of patients which has
Who are
exactly
identical with identical tumors? Yeah.
that combination of alteration? Well, that's hard. So that challenged a lot, some older principle, which is still a bit in line. How do you validate? Yeah, it's hard. So now, the way to validate is to compare to, how did the tumor do with a previous treatment when you have a relapse refractory tumor? And do you manage it better with a treatment which is more personalized when it's relapse? So you compare to the earlier behavior of the tumor, but it's also not a good comparison because in between the tumor evolved. So that's a kind of a catch-22 situation when it's super hard to make assumption of how a tumor will do. You can predict, yes, sure, but yeah, certainty is very difficult in that field.
Yeah, that's it. I think, and the important thing, as you're doing, as we talked about, is to just understand the biology and the genetics of tumors more deeply, so that you can make better predictions, from the start without needing to, without having to rely on the validation that's just not possible.
Yes, and I am glad that you kind of wrap up with this comment, because we have to go back to the beginning of the coin word precision oncology, personalized oncology, and it's exactly that. When you read the definitions of this, is to be able to treat a patient based on the molecular characteristic of his tumor. So that is a personalization. So by definition, that is complete contradiction with having a same cohort to validate. Of course, one has to validate as much as possible. The question is not to start treating with an haphazard set of drugs and see what's up. It's not at all what we are talking about. But there is a limit to what we can validate. And even in the validated drug for one entity, the fact is a number of patients are not going to respond or are going to have adverse effects which are not predictable. So going more personalized is not bringing more risks, because treating with less information brings as many risks, if not more, than treating based on the information. So that's more than a philosophical question. That's really a difficult question, and I understand that for the oncologist, there's always a dilemma what to choose as a therapy, because it's not exact science, it's not mathematics, it's evolving biology of the tumor.
Yeah. Yeah, no, I agree. That's a really interesting point to end on. So that's been a fascinating discussion, Marie. Thanks so much for your time.
Thank you.
Do you have any other closing points to finish on, or?
No, I think that we went through more or less what we wanted to discuss. Yeah, one of the finishing point is never give up and keep trying to push the technology, harness the knowledge, and so on, to be able to try to deliver the best possible diagnostics and therapy for the patient. But that's an evolving field, that's an always moving dynamic target.
Yeah, I agree. That's a really interesting, and it's a really important point to finish on. So we'll wrap up there. Thank you so much, Marie, for your time, for sharing your expertise with us. I thought that was a really fascinating discussion. And to everyone listening, I hope you thought it was fascinating as well. And I hope you'll join us for the next episode.